Recording in progress.
Good evening and welcome everyone to our webinar this evening. It's great that so many of you will be able to join tonight from all over the world, and we're so glad that you can make it. I just want to say a big welcome tonight to our speaker, Dr. Murad Senussi. He's an assistant professor at the University of Baylor Medical, who will speak on Congestion Cascade, harnessing the power of the Doppler. Dr. Kerala will introduce him at the end. So I just want to say a big welcome also to our other panelists. We have Dr. Mazen Kerala, who I'm sure you're all very familiar with, Dr. Shana and Dr. Abhishala. So again, thank you so much for joining us today or tonight, wherever you're joining from. And I'm just going to let you know that if you have any questions during the webinar, there is a question and answer section that you can add questions to at the bottom. And during the webinar, we will be able to answer the questions for you. I'll now pass over to Dr. Mazen to introduce our speaker tonight.
Thank you very much indeed, Grace. It is my great pleasure to welcome Dr. Senussi. I got to know Murad through a fantastic grand round that I attended at University of Alabama. And I thought he can share his expertise and knowledge on ICU Reach platform. Murad is an assistant professor at Baylor Medical College, and he is the director of cardiac critical care unit at St. Luke's Hospital in Houston, Texas. He completed his residency in Chicago, where I live, actually, and he moved to Cleveland Clinic for his fellowships. He did critical care and cardiology fellowships before he ended up in Houston. With his background in cardiology and critical care medicine, along with his interest and publications on ultrasound use in the ICU. He has multiple publications, including ultrasound use in the ICU. I cannot think of a better candidate to talk about using the ultrasound Doppler in the ICU, specifically the topic of fluid assessment. He has a unique way of putting together things about assessing the fluid status in the ICU patients, mainly the over-resuscitation of patients in the ICU. He's also a great teacher, as witnessed by multiple residents and fellows who I know at Baylor, and he's a receiver of the Faculty of the Year Award at least 3 times over the past 3 years. Dr. Murad, thank you very much for joining us and sharing your expertise and knowledge on ICU Reach platform. The podium is yours.
Yeah, thank you so much. It is an absolute pleasure. Can everybody hear me?
Yes,
okay.
We hear you.
All right. Can you see my screen?
No.
All right. How about now? Can you see my screen? Good. Excellent. Well, thank you so much for that introduction. It is truly, truly my utmost pleasure to be presenting, especially when it comes to something that's so wide reach when it comes to different people from different parts of the world. Today, I'll be talking about the congestion cascade and how we as intensivists can harness the power of Doppler. Now, if you've never heard of the term congestion cascade, do not fret. That's okay. It's the term that I coined. And I think it's an important way of looking at volume status, and that way we can make the right decisions at the bedside. My objectives are going to be very simple. We're going to talk very briefly about these concepts that we already know, venous return and fluid responsiveness. We'll talk about the traditional methods of how we assess volume status and how it's really failed us. I will introduce you to these congestion parameters, some of them which a lot of people here may be familiar with, some a little more novel, and how you can use it for your patients. I will be going through lung portal vein Doppler, hepatic vein Doppler, and final intrarenal venous Doppler. We'll actually go through some illustrative examples, real cases where this can actually be put to use. And then finally, we'll top it off by really going through my method of going through a POCUS-driven approach for anyone who has undifferentiated shock and how you can incorporate the congestion cascade in it. Okay, so as far as hemodynamics goes, we've really forgotten Guytonian physiology. And there's one part of the hemodynamic system that we do well, which is maintaining cardiac output. And we understand the tenets of cardiac output. We know that to maintain perfusion, we need to maintain a mean arterial pressure. It's a very simple concept, easy to implement. We have obsessed over oxygen delivery, which again, there is some controversy about whether we really should be delivering that much oxygen to patients. But the general understanding is by maintaining hemoglobin and oxygen saturations, the main determinant of oxygen delivery usually becomes cardiac output, as long as the hemoglobin and the sats are okay. And so we've often developed this means of measuring cardiac output, whether it's non-invasive and invasive, and that's how we fine-tune the management. We increase vasoactive agents, inotropes, and we monitor the cardiac index either invasively and non-invasively. This has become very simple. It's become cornerstone in the management of our critically ill patients. However, welcome to the dark side of the moon, and this is venous return. And this is the part of the cardiovascular system that is often neglected, but plays a crucial role in our patients and their survival. So in order to understand venous return, we have to understand pressure gradient. So if you have a patient who has a MAP of 75, and a right atrial pressure of around 0 to 5, which is our normal central venous pressure, there is always forward flow going from the upstream pressure to the downstream pressure. However, we also have to think about what is driving flow from the post-capillary venules into the capacitance vessels, into the resistance vessels like the IVC and SVC. There has to be a pressure gradient between the post-capillary venules and the right atrial pressure in order for forward flow to continue. And this is what we call the mean systemic filling pressure. And although clinically we don't measure this, this can be measured experimentally. And we know it's around 8 to 10 millimeters of mercury. So now you start to realize that there's a very delicate balance here. There is a gradient for sure, but it's a small gradient. The delta between the mean systemic filling pressure and the right atrial pressure is very low. And so if we conform to the previous guidelines, for example, surviving sepsis guidelines that recommends giving patients volume up to until their right atrial pressure is up to 8 to 12, you run the risk of not only increasing the mean systemic filling pressure, but increasing the right atrial pressure at a degree higher than the mean systemic filling pressure. So you may have a right atrial pressure of 12 and a mean systemic filling pressure of 10. What that means is that you're always going to have backflow or back pressure that leads to venous congestion. And why is venous congestion important? Because in encapsulated organs such as the liver or the kidneys, you'll start to note increase or worsening function of these organs because of venous congestion. Mind you, all this time you've maintained a normal mean arterial pressure above 65. You are delivering oxygen like you've been trained to. However, you will have worsening renal function, and you also start to see splanchnic fluid overload. So because of that, over the last decade or so, we've started to learn and to realize that we need a better method or system by which we can gauge which patients need fluid and which ones don't. And this is where the whole concept of volume or fluid responsiveness has come to play. And it's defined as an increase in stroke volume of greater than 15 to 20% with a standardized fluid bolus or a passive leg raise, which is nothing more than an auto transfusion of 300 cc's from your splanchnic circulation. We give this fluid and we have a means by measuring cardiac output. And if you see that the stroke volume increases, the patient is now deemed volume responsive. Here's a small illustration to kind of show this to the audience. Here, this patient's stroke volume is low. This is a representation of low stroke volume. You give the patient a 500 cc bolus, suddenly you have an increase of more than 15 to 20%. However, if you give any additional fluid boluses, you'll notice that there was no change in the patient's stroke volume. There was no increase of 15 to 20%. Thus, you've actually reached a point where the patient is no longer fluid responsive. And that is a hard stop where you should not be giving any more fluid. Why? Because any additional fluid beyond this point contributes to nothing more than rapidly increasing your central venous pressure and upsetting that gradient that we were talking about and leading to nothing more than organ dysfunction. And this really falls back to the Starling curve. We really want to, whatever your patient is, we really want to be in the ascending limb here. Once you get to the steep part of the curve, you'll see that whatever fluid bolus you give brings about a very small increase in stroke volume. And this is what we truly want to avoid. This is an example that I give everyone. We are all, our natural physiological state is to be volume responsive. We all have collapsible IVCs. If we suddenly develop an infection, we're injected with an endotoxin, just because we become septic and more vasoplegic doesn't necessarily mean we have to keep giving this patient volume until they reach that point where they're no longer fluid responsive, because you've entered into the danger zone where now your organs are congested. So from just a very brief historical perspective, early goal-directed therapy for sepsis in the early 2000s kind of guided the way. And what happened were people were getting over-judiciously fluid resuscitated. And we started to realize over the years that in all comers, whether it's post-surgery and septic patients, whatever it may be, all comers were developing more organ dysfunction and had poorer outcomes if we gave them more fluid, even if you accounted for their severity of illness, because sicker patients, let's face it, get more fluid. But even if you account for that, they were getting poor outcomes. And the reason was because of this venous congestion. So now we've been more aware of the dangers of giving too much volume. And then we started using things like volume responsiveness, but we still need a better means of assessing fluid status. And when I say fluid status, I mean central volume. So we've all used the Swan-Ganz catheter. Unfortunately, the Swan-Ganz catheter has been slandered in the critical care literature. The reason being that a multitude of studies that looked at it showed no benefit. We all understand that there's a heterogeneity of treatment effect, meaning a few patients will benefit, some will have a neutral effect, others will have a positive effect. However, when you try to implement something like this in a ICU population, there's always inherent problems with the study designs. And again, the mixed population, it's hard to come to concrete conclusions about it. But ultimately, especially in my practice, especially in patients who have a mixed picture or who have, for example, need for mechanical circulatory support, this has been instrumental. The key concept here is that if you don't know what to do with the numbers, you're going to do the wrong thing. And therefore, don't blame the SWAN, blame the people who are interpreting the SWAN numbers. So this brings us to the IVC. And about 5 to 10 years ago, this has taken off. And one of my biggest pet peeves is those who use the IVC as a surrogate for volume status. And that's not the way we should be using the IVC. The IVC, like many things in medicine, it tells us something, but we think it's telling us something else. So the surrogacy is the issue. So here's an example of two patients, actually the same patient. This patient has a collapsible IVC. This is their normal physiological state. They were placed on positive pressure ventilation, and you can see that they have a very plump, large IVC. There's actually no change whatsoever in the volume status of this patient. The only difference is the changes in interthoracic pressure. Now, in the same ilk, you can also say that in a patient who has suddenly an obstructive PE, what's going to happen? Your right-sided filling pressures are going to go up, and then your IVC becomes large. That's not because there's an increase in your volume status, but rather a congestive process, something that's led to a congestion point in the pulmonary artery that now leads to back pressure. The answer to the treatment would not be to diurese this patient with a massive or submassive PE. And so we really need to move away from using the IVC as a surrogate for volume status and rather use it as a barometer to the right side of the heart. And so it did fail, and it failed because we didn't know what to use it for. And again, I reiterate, this is a barometer for the right side of the heart, measuring pressures or filling pressures. Should never be equated to volume status. And always remember, the collapsible IVC or the volume responsive state is our natural physiological state. Over resuscitating patients to the point where they're no longer volume responsive, we're starting to learn is not the right way of doing it. And I think you guys have a webinar coming up about de-resuscitation in sepsis and septic shock. This is one of the key points, that we should not reach that point where we're over resuscitating patients. And again, we have this overwhelming need to keep on giving fluids when fluids may not be the answer. So enter the venous excess or venous congestion concept that I explained. Over the last few years, if you're watching social media, you'll see that a lot of people are pushing for what's known as the VEXA score. And this is fantastic because it actually put up front on center stage the use of Doppler, looking at different vascular beds to decide whether or not you're going to fluid resuscitate or de-resuscitate the patient. I like this VEXA scoring system. It's simple, but it needs to be used with caution. And the reason is because each different component of this VEXA scoring system, you have to know the variations that happen in physiology and pathology. You have to understand your waveforms in detail before you start implementing a simple scoring system. Another thing that's lacking, I believe, in the VEXA scoring system is inclusion of the lungs as well. And that's why I think it's important for anyone at any level, medical students, residents, trainees, or attendings, is to take a look at the whole cardiovascular system as a congestion cascade, starting from your aortic valve all the way back into your hepatic, portal, and intrarenal venous vasculature. So we'll start with the first congestion parameter. I'm sure many of you use this very briefly. You're looking at artifacts. This is the art of interpreting artifacts. Very simply put, a well-aerated lung shows a horizontal reverberation artifact. And we know that a lung that's full of whatever fluid that may be should lead to a vertical reverberation artifact. And this is the basic concept. Here's an example of someone who has just A lines, and this is, again, the horizontal reverberation artifact, consistent with someone who probably has well-aerated lungs. Again, this is a different probe, but again, you can see the A-line pattern. Here's someone who has B lines. These are vertical reverberation consistent with increased extravascular lung water. Another example as well. And again, someone with florid pulmonary edema. Now, when you use the lung ultrasound, you can very quickly develop a differential diagnosis depending on your profile. Is it an A-line bilaterally? If the patient's hypoxic, you think of COPD or PE. If someone has a unilateral B-line profile, you think about someone who has pneumonia, potentially eccentric MR, which is extremely rare. Lastly, you have a B-line profile, meaning bilaterally you have these B lines, and that's consistent with someone who has a bilateral opacities on their chest X-ray. Now, there are some methods by which you can try to distinguish cardiogenic from non-cardiogenic pulmonary edema. I don't find it as helpful unless you truly see patchy involvement, but a lot of people started saying that the lung ultrasound is now the next key to understanding how to determine someone's volume status. And I would say that this is not the answer we've been waiting for. It's a resounding no when it comes to whether lung ultrasonography can tell the difference. And the reason is very simple. If you take a look at the spectrum in this patient, here's a patient, we're looking at inflow, mitral inflow patterns, telling us whether or not the patient has high left-sided filling pressures. So in this example here, you have normal filling pressures, you have no hemodynamic congestion, and you have no congestion in the lungs. As your left-sided filling pressures start to increase, you'll start to have hemodynamic congestion. This is measurable if you had a swan, for example, or even non-invasively. But until that fluid starts to extrude into the lung, you will still have a B-line pattern. So you can still have poor LV dysfunction, you can still have high left-sided filling pressures, but only until the patient decompensates will you start to see B-lines. And that's what happens down here where you see the pulmonary congestion. So you may find a patient who's in between this spectrum here. And if you looked at the lungs and said this was an A-line pattern and the patient was not volume overloaded, you would be sorely wrong. And the best examples I give is, for example, someone who has bilateral opacities on the chest X-ray is being labeled as someone who has severe hypoxemic refractory respiratory failure, who now has ARDS. But if you take a quick look at their mitral valve, you'll see that the patient has severe mitral regurgitation. And it is a high left-sided filling pressures that's leading to congestion in the lungs. Had you scanned just the lungs alone without looking at the left side of the heart, you would have made an assumption that this patient had non-cardiogenic pulmonary edema. So let's move on to the interesting novel parts of the congestion cascade. And one of them is the portal vein. The portal vein is an amazing vascular structure which drains the mesenteric veins, the gastric, the splenic, etc. And it's very important because it gives us an idea about splanchnic circulation overload. So when you're congested in the splanchnic circulation, you can start to detect changes in the waveform in the portal vein. It's very easy to detect the portal vein. You just take a very simple transhepatic view, just like how we start looking for pleural effusions laterally along the chest. From there, as long as you have a good view of the liver, you can find your portal vein by just a small anterior tilt. And then you know the flow is usually going to be towards the liver, so the flow is going to look red. All right, here's how it looks like. This is a curvilinear probe. You can see that the flow is red. This is called hepatopedal flow because it goes from the splanchnic circulation towards the liver. And so you'll notice that it is red. Now, the characteristic flow patterns for the portal vein is quite simple. It is a venous hum. It's like a waterfall. It's a straight line, monophasic flow. Just think of it as a flow going continuously from the splanchnic circulation into the liver. Now, as you start to give the patient a little bit more fluid, you reach that point where the patient's a little more, is no longer fluid responsive, you will start to detect small variations in the flow. It's no longer that neat, linear, monophasic flow. You'll start to actually see a little bit of phasicity or pulsatility. As you continue to give this patient more fluid, you will start to see a stark contrast between the peak and trough. So you actually see very clear pulsatility between the peak and then the lowest form as well. If you continue to give fluid, here I purposely showed the portal vein as blue. The portal vein should never be blue. Blue means it's going in the opposite direction. Remember, it is venous flow that always goes from the splanchnic circulation to the liver. Here, in this case here, you have such an incredible amount of congestion in the splanchnic circulation that your waveforms are not only pulsatile, they've become biphasic. They've actually come and they descend below the baseline. So for almost a third of the cardiac cycle, you actually have backwards flow. And this is a very bad sign. So here's an example of a patient who came in with urosepsis, urinary tract infection leading to severe septic shock. Patient was on pressors, was given a considerable amount of IV fluids, and you can start to see the pulsatility. What we did is despite the fact that the patient was on low-dose vasoactive agents, we actually proceeded to diurese this patient. So we're no longer just looking at these traditional markers. We're actually trying to normalize the waveforms from this pulsatile waveform to this flat waveform. And as we diuresed the patient actually came off of vasoactive agents. So that is one way we're looking at the portal vein. And the next we'll talk about is the intrarenal venous Doppler. Intrarenal venous Doppler is, again, a very easy vascular congestion parameter that you can pick up. Again, looking through that transhepatic approach, you're going to go down posteriorly until you find that kidney. You're going to put color on it. And because we're looking at the intrarenal venous structures here, you're going to see a blend of both arterial and venous waveforms. For now, we're only going to focus on everything that's below the baseline, which is the venous waveforms. And you can see that normal venous waveforms are what we call continuous. Although you may see a little bit of pulsatility during systole and diastole, for the most part, the most important key feature in the kidney is that it is continuous flow. This is healthy flow in the vasculature of the kidney. As you start to develop more renosarca, meaning that there's more edema in the kidneys or you're getting more venous congestion like what we talked about, you start to clearly see more pulsatility that correspond to the cardiac cycle. So systolic, diastolic, systolic, diastolic. And this is what we call discontinuous flow. As you give the patient more fluid and the kidneys become more congested, now what happens is that S wave will demonstrate flow reversal. So it blends into the arterial waveform. And now you're left with only monophasic discontinuous flow. So the spectrum becomes quite easy. This patient has monophasic flow that is continuous. Once you start to develop pulsatile flow that's discontinuous, you are now past the point where the patient is volume responsive. And now if you've reached very discontinuous flow with only monophasic flow, you know that you are at the end of the spectrum. And as the spectrum works in the one direction, it also works in the other direction. As you diurese the patient, you can see reestablishment of the normal waveform. Here's an example of how it would look like on Doppler. Above the baseline is the arterial waveform. That's not what concerns us right now. What we're looking for is that beautiful monophasic waveform with just minimal pulsatility. As the patient becomes fluid overloaded, look at this. Each cardiac cycle has two waveforms. So it is phasic or pulsatile. It's discontinuous, but it at least has two waveforms that correspond to each cardiac cycle. Once you lose that systolic waveform, that systolic waveform reverses, and all you have is very interrupted discontinuous flow that is only monophasic, you know that this patient is in dire need of some way of removing volume. Again, this is the spectrum. Remember it well. It will serve you well. Flat monophasic, pulsatile discontinuous, but at least it's biphasic. And here's one who has only monophasic flow. That brings me to one of the last congestion parameters that I use, and that is hepatic vein Doppler. And for me as a cardiologist, I believe that this is the most telling. The reason is because the hepatic vein, unlike the portal vein, directly drains into the IVC, and the IVC without any valves in between is a direct connection to the right atrial pressure. And so any pressure changes that occur can be detected. This is analogous to your jugular venous waveforms. The only difference is when it comes to nomenclature, we just place a line through here, and instead of talking about X descents and Y descents, you have a retrograde A wave, you have an antigrade S wave, a transitional V wave, and you have an antigrade D wave. This is because this is systole and this is diastole. So this is where you really need to break down the components of the hepatic vein, because it tells you so much more about the right side of the heart. And when I say the right side, the right heart apparatus, it tells me about rhythm, it tells me about the tricuspid valve, it tells me about the RV, and it tells me about the pulmonary pressures as well. All right, so very important to correlate your electrical and your mechanical events. So if you look here, the P wave initiates, remember, the atrial contraction. You're looking at the right atrium from a back seat in the hepatic vein. And so when the atria contracts, it causes retrograde flow. That's completely normal. Retrograde flow is going to be above the baseline. We call it the A wave because it comes from the atrial contraction. The peak of the R wave is what signifies or signals the contraction of the RV. Remember, the right ventricle contracts by actually moving and pulling the tricuspid valve down. So it has this circular pulling movement. And this circular pulling movement, what it does is it increases the size of your atrium. And in doing so, now the hepatic vein, because there's less pressure in the right side of the heart, the flow will increase from the hepatic vein into the right atrium. And that's why you see systolic flow. And as the atrium continues to fill, it'll reach a point where the pressure in the right atrium overcomes that in the right ventricle. And when that happens, that's when the tricuspid valve opens. And now you have flow during diastole, and that's the D wave. So A wave, S wave, D wave. S wave is during systole, D wave is during diastole. Again, very easy to do. It's exactly the same position, the trans hepatic view, like when you're looking for a pleural effusion. You put pulse wave Doppler at the level of the hepatic vein, and that's when you get your hepatic wave form. You have to understand the changes that occur in these hepatic waveforms during pathology and during normal physiology. Because if you don't, you may make a mistake into thinking that the patient is volume overloaded when it's actually just a normal part of physiology. And this is a very good example. Here's the patient. Whenever you take a deep breath in, there's increased flow, there's increased venous return to the right side of the heart. Therefore, you should see an increase in antegrade flow. So when a patient breathes in, there is increase in flow during systole and diastole, and vice versa. With breathing out, it's quite the opposite. The retrograde waveforms become larger, but the antegrade waveforms become smaller. This is the same patient. The only difference is a different phase in inspiration and expiration. And this is how you look at it here. Always orient yourself to the bottom here where you have your EKG leads. Remember, we said that the R wave signals the beginning of the S wave. That's tricuspid valve will descend because of RV contraction. So my eye is drawn to that R wave. I know immediately that that antegrade waveform is an S wave and the one after it is a D wave. Look at the differences in flow during inspiration, expiration. Inspiration, expiration. You can see that the magnitude of the S and D waves decrease when you expire, and it increases when you inspire. That doesn't mean the patient's volume status has changed in any way. Another good example of a really deep breath, and you can see an incredible increase in forward flow. Again, another example, but this is during expiration. Look at the flow reversal that has occurred during systole and diastole. Again, this is during someone who's breathing out. All right. A very important concept is a good atrium. The heart loves compliant structures. When you have a compliant atrium that actually augments forward flow. What does that mean? When you contract your atria, you'll see the retrograde waveform. As the atria relaxes and it's very compliant, it will bring down the pressures all the way down to this notch here. And this is what we call S1. Then the tricuspid valve will descend because of RV contraction, and now suddenly you have an increase in forward flow. If you did not have that relaxation phase of the atria, what would happen is that it would be blunted in terms of the forward flow in the S wave. So instead of having a large S wave like this, you're actually going to have a very small S wave. And that has hemodynamic effects as well. Here's a very good example. Large atria that's contract has led to some retrograde waveform, but because of the relaxation, it's come all the way down the baseline. Now when contractions occur, you have a significant forward flow, which is great for hemodynamics. And this is how we see people with diastolic dysfunction who develop AFib. They suddenly lose their atrial kick and suddenly they become hemodynamically unstable. All right, so now that we understand, let's look at the components. The atrial reversal wave is very important. It could be either absent, it could be prominent all the time, it could be prominent sometimes, or it could be biphasic. And what does that mean? So this is very important because in atrial fibrillation, like I explained, you've lost your atrial kick. And if you've lost your atrial kick, you don't have that augmented flow. It doesn't relax, and so your S wave is not large. And so what do you start to see? You see no A wave, and you see very small S waves. And what that tells you, this is not because the patient is volume overloaded, this is because the patient has lost atrial kick. And that's why I tell you the hepatic vein is not just for volume status, but understanding atrial dysrhythmias, understanding tricuspid valve issues, as well as the RV. Here's someone, and this is an example of someone with AFib, small S waves. This is not systolic blunting because of volume overload or tricuspid regurgitation, not at all. Here's an example of someone who has atrial flutter. You can actually see the flutter waves here. And then in a few instances where the flutter waves fall on the R wave, you can actually see a large atrial reversal wave. And that's because it was during tricuspid valve closure. And clearly you can see the flutter waves at the baseline. So remember, in cases of atrial fibrillation, you've lost, so you could be completely lost your atrial waveforms, your retrograde waveforms, or you can have prominent waveforms in flutter when they occur at the same time as the R wave. So that brings us to when we see atrial reversal waves that are prominent and prominent all the time. So you need to start thinking about a fixed obstruction on the right side of the heart. So we already talked about, so for example, there are certain dysrhythmias like AVNRT, right? AVNRT, you have retrograde P waves or P waves that are really close to the R wave. And guess what? Because it occurs at the time of closure of the tricuspid valve, you're going to have incredibly large retrograde A waves. And these large retrograde A waves are not flow reversal because of, for example, regurgitant valves. It's actually because of the close proximity of the P wave. This does not mean that the patient's volume overloaded. This is merely a way you can actually even diagnose your SVTs by looking at your hepatic waveforms. Number two, looking at the tricuspid valve, this is not a very common clinical entity, but this is tricuspid stenosis. And here you can see massive, giant retrograde A waves as well. Now, you can also have intermittently prominent A waves like we talked about, but one important reason is when you have PVCs or you have heart block. PVCs and heart block, similar to atrial flutter, whenever that wave hits the tricuspid valve, when it's closed, you'll start to see retrograde A waves. And this is synonymous to the Canon A waves that we talk about when we look at the jugular venous vein distension. All right, this is very important because sometimes you cannot show the prominent A waves unless you unmask, for example, issues with RV compliance. So for example, if a patient's breathing normally, they look okay. But when you take a deep breath in a patient who has poor RV compliance, suddenly you have an increase in right-sided filling pressures, and now you have large retrograde A waves. So you can actually unmask poor RV function or pulmonary hypertension by taking a deep breath. Obviously, if you have very poor function at baseline, sometimes you don't even need to take a deep breath. You'll actually see these retrograde waveforms in every cardiac cycle. So now you start to develop a differential here. Are they absent? Is it normal, or are they prominent? And if they're prominent, is it regularly prominent all the time, or is it just intermittent? And that really breaks down the hepatic waveforms instead of just simply saying whether you think the patient's volume up or volume down. So this is the S wave. So we've talked about the A wave, and I think the S wave is by far the most important take-home message you can take, especially if you do critical care when you're looking at hepatic veins. If you look at the bottom, normal S waves are usually larger than D waves. So remember, S is greater than D. As the patient becomes more volume overloaded, S becomes less than D, then we say that this patient has systolic blunting. Sometimes you'll have no flow because it's at baseline. And then other times when you have severe volume overload with, let's say, tricuspid valve regurgitation and RV dysfunction, a combination of all this together can give you what we see as systolic flow reversal. So instead of it going forward antegrade, it's going retrograde. And this is the most severe form. Again, use that systematic approach. There's something wrong with the atrial contraction. There may be a volume issue, a valve issue, or something wrong with the function of the heart. We already talked about the lack of atrial contraction. If you have AFib, you're going to have small S waves. Tricuspid regurgitation is also a very important part of why the S wave may become blunted or reversed, as is RV dysfunction, as is volume overload. And let's take a quick look at this. The S wave during tricuspid regurgitation, it's very important to understand is that because you have a valvular structure and then you have valvular regurgitation, the volume increases during late systole. So think of a leaky valve. So the more systole progresses, the more leak you have. And so you will see late systolic flow reversal. So you may still have a blunted S wave, but the most important part is a late systolic flow reversal. And here's an example of it. So remember, with the regurgitant volume increases as systole progresses, therefore you see a late systolic flow reversal. With RV systolic dysfunction, it's the opposite. Because there's such poor function up front, you're going to have early systolic flow reversal, but you still may maintain your S wave. We know that the tricuspid regurgitation, RV dysfunction oftentimes occur together, and therefore, when you see a combination of both early and late systolic flow reversal, that's when you see what we call pansystolic or holosystolic flow reversal. This is the biphasic waveform that goes up and down, up and down. This is really severe. You have TR, volume overload, RV dysfunction, or a combination thereof that has led to this. And this patient really has extremely high morbidity and mortality. So there again, in the S wave, not only do we know how it looks like in terms of it being diminished, but we also understand reversal, early versus late versus pansystolic. And now you're really equipped to understand what the hepatic veins has to offer. Now, very briefly, we can use also the D wave to look at flow reversal during constriction and restriction. Again, not a part of the topic today, but I wanted to mention it. Bonus points for people who use pulmonary veins. Since you know how to use hepatic veins, pulmonary veins, this is with TEE, actually gives you the exact same waveform, except it's in reverse. So the atrial reversal wave goes pointed downwards, you have the S wave, and you have the D wave. And so you can actually assess volume, you can assess the severity of mitral regurgitation by using the pulmonary veins. All right, so now we've kind of created a spectrum. We can actually examine these patients and look at different vascular beds. And as the patient becomes more congested, you can actually figure out where that congestion is, and you can start instituting therapies and following these waveforms. So we've really brought you back to physiology, back to the bedside, and back to normalizing waveforms. So I'm going to quickly go over a few examples where you can actually assess central volume overload and how helpful this can be. Here's a patient in their 60s, post-CABG, it's post-operative day 1, not doing well from a respiratory standpoint. You can see, not very clear, but you see the subxiphoid view. You can see the longitudinal movement of the RV. The LV looks hyperdynamic. So I don't think this is the biventricular function looks preserved. If you look at the IVC, the IVC looks collapsible, doesn't add much information for me. And then I take a look at the hepatic veins. Look at that blue flow. Blue means it's draining directly into the IVC. There's no reversal, but you can clearly see that there is predominant antegrade flow with very little retrograde flow. So this is antegrade hepatic vein flow. If you look at the portal vein, the patient's portal vein is completely flat. This tells me that this patient does not have central volume overload. I disagree with diuresing the patient. We actually, after doing a lung ultrasound, found a patchy area of B lines, and it looked like this patient aspirated shortly after extubation. This was mainly due to aspiration pneumonia. And diuresing this patient may have led to worsening renal function, which we avoided. This is a 50-something-year-old woman with COVID-19 who has pneumonia, worsening AKI, and hypotension. If you look at her lungs, bilaterally have B lines, not very helpful to me. I don't know if this is cardiogenic or non-cardiogenic. If you guys can see here, you have a very hyperdynamic LV, really not helpful for me either. So when I did the hepatic waveforms, you can clearly see they're biphasic. This is bad news. This is systolic flow reversal. Also, the portal vein shows considerable pulsatility. This patient is volume overloaded. Despite the fact that this patient is on vasoactive agents, my next step was to remove volume. She was oliguric waveforms after 2.5 days. You can clearly see a reestablished S and D wave. This is exactly what we want to see. And again, as we pulled volume off this hypervolemic patient who was still hypotensive, pulling off that volume actually reestablished that flow in the venous return. And suddenly you find that your patient, as you remove volume, becomes more hemodynamically stable. Next, we have a 28-year-old with tricuspid valve endocarditis. This patient had respiratory failure, again, worsening shock and acute kidney injury. Again, because of the right-sided valvular disorder, there was embolic manifestations in the septic emboli in the lung. You can clearly see B lines everywhere. And if you look at their echo, you can see here clearly that mass, probably infective endocarditis, and it's leading to, I didn't show the color here, but had rip-roaring tricuspid regurgitation, so very severe TR. So the next step is, what do we do? The patient has AKI. Patient has tricuspid valve regurgitation that's severe. What do we do? The CDP is very high because of that regurgitant valve. So we take a look at the hepatic veins. Now, clearly you can see here that there is systolic flow reversal, right? And then the systolic flow reversal is late systolic flow reversal. And the reason it's late is because, again, as the systole progresses, there's more and more flow at the end. So it's late systolic flow reversal. So I know that this is mainly because of what? The tricuspid regurgitation. It's not a reflection of my volume status. I need something to assess the central volume a little quicker and better. And that's why I use the portal vein. Now, although there's a little mild Pulsatility, it's not significant. So our decision in this patient was not to diurese this patient, but in fact, to give this patient more volume. And because we gave this patient more volume, their renal function, their creatinine, which was 4, came down to 2, then came down to 1. This patient was cleared for surgery and got what they needed, a tricuspid valve replacement. All right, this is the last illustrative case example. A 60-year-old man who has AKI and respiratory failure is transferred from an outside hospital. We were told that he had extremely high left ventricular end diastolic pressures, and he had a BNP of over 1,000, again, in the setting of an NSTEMI, and again, in the setting of AKI. So this is actually pulled out of the chart here. Again, you're not always going to get the best waveforms, but look here. You can clearly see while the patient is breathing in, you have really good antegrade waveforms. So this tells me that this patient's right side of the heart is probably functioning well. And if you look at the portal vein, if you excuse this part here is where the translational movements when the patient is breathing in and out. If you look here, it's really flat. So this is very consistent with someone who does not have high left-sided filling pressures. All right, so the table of truth, we did a SWAN just to convince everyone that definitely this patient did not have high left-sided filling pressures. And if you can see the SWAN numbers there, we have near normal wedge, which is in the single digits. But again, this is something we obtained non-invasively. So now that we truly understand now how we can incorporate the hepatic vein Doppler and portal vein and intrarenal venous Doppler, how do you incorporate this all together when you're assessing a patient with undifferentiated shock? And this is what I call the congestion cascade. We need to start thinking like plumbers. We start at the garden hose of our cardiovascular system, which is the aortic valve. We look at the LVOT. And again, this is a process of looking at valves, pipes, and pumps. The valve, for example, the aortic valve, the left ventricular outflow tract, the left ventricle, back to a valve, which is the mitral valve, the pulmonary veins, lungs, RVOT Doppler, right ventricle, tricuspid valve, and finally, the IVC, hepatic, portal, and intravenous venous Dopplers. This may seem overwhelming, but when you practice it, it will give you the answer to your question. And we're not talking just about volume status, but where is that congestion point? And in order to incorporate this, I always tell people, this is my POCUS-driven approach to shock. And step one is always doing things that change management. If you will differ, if something you do will change your management or will be a fork in the road, then you need to do it. So it's usually number one is to rule out obstructive shock. We know how to do this. We do this well, whether it's cardiac tamponade, tension pneumo, or massive PE. We all know how this looks like. This is someone with McConnell's sign, and this is someone who has tension pneumothorax. How do I use the IVC in these cases? This tells me whether or not the patient is truly in obstructive shock. I don't use it for volume status. If they have any of the aforementioned issues, then you will see that the patient must have a large IVC if they have obstructive shock. Step two is now to work your way through. This is a stepwise fashion. I go through each and every one of them. Again, very simple to do if you do this systematically. Look at the aortic valve, look at the leaflets. Are they thin? Are they pliable? There's no thickening, no calcification. There's no way there's aortic stenosis. So you really want to rule out severe aortic stenosis, number one. Number two, the only other important aortic pathology other than dissection is trying to find out whether this patient has AI. So severe AI, severe aortic stenosis, and a proximal aortic dissection are the only major things I want to look for or at least rule out as an intensive septum. If someone has a thick septum and has SAM or systolic anterior motion, many times I come and see patients who've been dwindling in the unit because they're on inotropes and have worsening dynamic left ventricular outflow tract obstruction. So this is the next pipe that we're examining. Next is LV function. We have a very LV-centric view. We know how to detect global hypokinesis. We as we get more advanced, we can detect regional wall motion abnormalities. But a lot of people forget the hyperdynamic LV. This is as dangerous as the LV that doesn't function. And remember, if you have a hyperdynamic LV, you really have to start thinking about either conditions that lead to not enough blood flowing to the heart. So this is a preload issue. In that case, you have collapsible IVC and you have a hyperdynamic RV and LV. In those cases where not enough flow is coming from the right to the left heart, You really worry about RV failure. In these cases, your IVC may be plump, your RV may be large and dilated, but your LV looks hyperdynamic. Next is flow is coming to the LV, but it's not being ejected out of the aortic valve. It's being bypassed somewhere. So examples are severe mitral regurgitation or ventricular septal defects. You still will have a very hyperdynamic LV. And lastly, if your heart leaving the heart, flow leaving the heart without resistance, your vasoplegic pain, no afterload, guess what? The LV looks hyperdynamic. So if you find a hyperdynamic LV, it is a harbinger of doom. Take a look. Lastly, I'm just going to breeze through this. The mitral valve, the lungs we talked about, RVOT Doppler, RV and tricuspid valve we know, and then finally the hepatic and the portal veins we talk about. Lastly, you put this all together, and this is the final slide here, which is you need to figure out where along this congestion cascade do you think, is it consistent? Are the if let's say, for example, you have someone who has obstructive shock, you need to find evidence proximal to it that indicates that this is truly an effective point. If it's incorrect, as intensivists, I say this all the time, it's not about those people who are smarter, it's about those people who are more systematic. And finally, I'll leave you with this anecdote. Oftentimes, I will scan patients head to toe with my trainees. We had a patient with heart failure. We scanned for 45 minutes. We determined that they were volume down. When I asked the patient, "How do you feel, sir?" He said, "Sir, I'm as dry as a bone. You could have asked me 45 minutes ago." And that's just to kind of hone in the message that this is a tool that augments your physical exam. Nothing really can supplant that. And so use this as a tool. And with that, I'm more than happy to take any questions.
Thank you for your great lecture. We really enjoyed that. And I'm sure so many people who were listening also benefited and learned some new skills today. Somebody has put a question into the chat. It's more like asking you to comment on a few things because I think they're busy. The first is just regarding the subjectivity of physician experience when it comes to using ultrasound. Have you any comments on that?
Yes, I do. And, you know, there is a multitude of different opinions, and you'll see the same physicians examine the same patient and say different things. And so, yes, and we really want to remove subjectivity from the matter. And I find that if you truly understand your waveforms, physiology never lies, and physiology will give you the answer. The biggest problem that's happened in terms of the differences between physicians is that we rely on parameters that tell us things that we don't really understand. So that's where I brought up the example of the IVC. People equated it to the volume status and thus made wrong decisions. So I actually am a proponent of instituting these different congestion parameters because it really removes subjectivity. And I actually, when I examine my patients in the charts, I actually put images of these waveforms in the chart. And as we diurese or etc., I re-examine them and I actually show that difference.
Perfect. Before I ask any more questions from the chat, I'm just going to ask, do any of the panelists have questions for you?
Yeah, thank you very much, Murad. That was really interesting. Of course, one of the concerns would be those patients with chronic pulmonary hypertension. Is it going to be that easy to determine whether their volume status is in excess using this method, according to your expertise?
Yeah. So again, patients who have chronic pulmonary hypertension, again, it becomes very difficult. However, remember that the portal vein, this is why you combine two vascular structures. The hepatic vein is always going to show you flow reversal or blunting. And this is where people fall into problems. They say, well, my hepatic veins are reversed, let me diurese them, and you may get into trouble in someone with pulmonary hypertension who's very preload sensitive. That's why you need to combine two different vascular structures, the portal vein and the hepatic vein. Hepatic vein connects directly into the right side of the heart, so it will be affected by chronic pulmonary hypertension. The splanchnic, on the other hand, does not, except when you're talking to people who are in extremis and end stage, you will see pulsatility regardless. But that's why I use the portal vein. And it's even more useful than the SWAN. Why? Because it tells me about congestion outside of the heart. Because I'm okay with high right atrial pressures in a patient with pulmonary hypertension. That's where they live. But the portal vein should be flat or only slightly pulsatile. If I have a patient with chronic pulmonary hypertension who has obvious hepatic vein changes, who now has pulsatility in their portal vein, I will start to diurese them until I see minimal pulsatility. You will find that as you do that, the central venous pressure doesn't drop. If you continue to diurese beyond that point, you will then start to see the central venous pressure dropping, and now you've compromised your patient's forward flow. So to answer your question, absolutely. And I use another vascular structure, the portal vein, connected to the splanchnic circulation, instead of relying on patients who have chronic pulmonary hypertension on the hepatic vein.
So would it be the same answer for patients on high PEEP?
Absolutely.
Thank you.
Have any other panelists got any questions?
Yes, can I chip in, Grace?
Of course.
Yeah, well done, Dr. Senussi. Hi,
Thank
it's
you.
Hassan Hawa here. I'm a big fan of hemodynamics, and as you said, really, it's overwhelming, I must say, and I'm always scared when you start playing with the Doppler, and for those novices don't understand the echo as much. So I guess Dr. Mazen Kerala really pointed a crucial point, how we can assess the patient who's suffering with the pressure overload rather than the volume overload in patients like pulmonary hypertension. So can we possibly take a message from you today that, yes, you have to be systematic, but if you are stuck or you are not as good in doing all the things that you've mentioned, that we need to start learning how to assess the portal vein in addition to the simply done IVC?
Absolutely. And, I've seen, the world of POCUS has evolved. There's actually people who are trying to get into, speckle tracking, a global longitudinal strain. And I feel that's actually the wrong direction. We feel that we have to overcomplicate things to understand it. And this is very, very simple physiology. It's actually very easy to obtain these hepatic waveforms. The key is understanding them. And so, for example, I do workshops on the congestion cascade on vein Doppler, and within one session, an hour or 2 hour, supplement it. The problem is, what do you do with it? And this is why I always focus on the physiology, because I've seen people make the same mistakes like they do with the IVC. But as far as incorporating, I think it's far better to incorporate this than to try and teach your faculty or your trainees to do complex things like looking at valves and trying to understand global longitudinal strain or getting into TEE. This, I think, bang for buck, gives you more information about your patient. And as a cardiologist, it's very humbling because I learn more about the heart by just looking at other organs. And it took me several years to understand that, but finally I've come to that conclusion.
Well done, well done. Maybe a seed of thoughts for the future. Do you think AI would help us in the future? I mean, well, congratulations on coining this amazing congestion cascade. That's really amazing. But do you think AI might help us in the future, especially for those who are not as good in ultrasound?
Absolutely. I mean, we're all currently, in the infant stages of actually doing a study. For example, when you look at someone with hepatic veins, what we're doing is we're examining with AI area under the curve. So if you have antegrade flow and you have retrograde flow, and we're developing a ratio where if you have, our hypothesis is that if you have more retrograde flow to antegrade flow, you're not going to do well. And so you can actually use AI to just detect these waveforms and just spit out a number for you that gives you the ratio, for example. And so, yes, absolutely. I think we're headed in that direction. Portal vein pulsatility, by the way, most of the devices will automatically measure it for you. As long as you have a peak and a trough, you'll see the pulsatility index right away for the portal vein. So yes, soon we will all be replaced.
Fascinating stuff. Thank you very much.
But until then.
We will carry on. Thank you, Ernst. I'm done.
You're most welcome.
So Murad, I guess you go back and reevaluate after your intervention. And how easy is that going to be within a busy ICU of 12, 15 patients?
Yeah, I mean, so for me, when I round with the ultrasound machine. Part of my physical exam is a quick, check with the probe on that the transhepatic side and quickly checking the thing. I make my fellows do it every day. That's how they get better. But again, when I know I've made a clinical decision, I've gone down a pathway to remove volume and the patient's on CRT, I will come back in 4 to 6 hours to see if we're going in the right direction. The best part is it's very easy to obtain these views. I've timed my trainees, I've watched them do it, and I've seen people become almost expert level in less than 3 months. To just get the views really just takes one workshop. So I feel that this is easy to do. And it also gives people a clear thing to follow. Another thing I do is that before we put in swans in patients or before they go to the cath lab, I tell them why don't you scan this patient, do the congestion cascade, and you tell me what you think their numbers look like. And so far, they've been doing an amazing job.
Just a further question. How often do you find that right heart catheterization in cardiogenic shock provides incremental value over comprehensive ultrasound? And in what situations do you still use SWAN?
Okay, so I still use SWAN heavily. And because my practice is not only the CCU, but I'm also in a cardiothoracic ICU as well. And I manage a lot of ECMO patients who have mechanical circulatory support. So I still find that it's valuable, very valuable to know your right heart cath. But the same thing with the SWAN, junk going in is junk coming out. So if you don't know how to measure, or you don't know what the numbers are telling you, you don't know what to do with the numbers, you're not going to have good outcomes either. It is oftentimes the way I look at it is that if a patient's really sick and I'm still confused about the picture, sometimes I will then put in the SWAN to kind of confirm everything. As the patient gets less sick, then the SWAN comes out, then I start to use a non-invasive more. This congestion cascade I usually use in the initial stage when the patient is undifferentiated, and it really helps me break down what's going on. Now, I will still use the right heart cath. I'll still use a SWAN when I'm titrating, for example, inotropes. I will monitor the right heart filling pressures very, very closely, but non-invasive, someone who's very, very sick most of the time in my unit, I'm biased because it's a cardiac unit. There are a lot of people with MCS. I will end up using the Swan-Ganz catheter. But I believe in a MICU environment, you can really get away with just doing the congestion cascade.
Thank you. Does any other panelist have a question before I keep going with the chat questions? Okay, so another question in the chat. What is the approach in your ICU after a patient receives 30 mils per kilogram fluid bolus? And how often do you assess the volume status?
So the 30 cc kg part of the guidelines, most of the time, by the time the patient has landed in our unit, they've already received this in the emergency room. And then I am a proponent to giving as much fluid as the patient needs. I do not want to reach that point where the patient is no longer volume responsive. That is actually a hard stop for me. In fact, if a patient reaches that, I'll start to diurese. What I usually do is that since patients have already received the 30 cc's per kg, I will do a congestion cascade assessment, and I will look at the hepatics and portals specifically. If the portal vein is completely flat, that tells me that the patient is fluid tolerant, meaning that you can still give them fluid. And so, especially if the clinical picture makes sense, I will give additional volume boluses. When I start to see pulsatility in the portal vein is when I'm going to stop. Now, there's a very big difference between a 70-year-old woman who's had 100 bowel movements because of C. diff and has pneumonia and tachypnic versus another patient who has, let's say, another infection, but it's only been a day or so. So patients are different. I may end up giving one patient 3 to 4 liters and another patient just 1 liter. But what guides me is the congestion in the organs. If there is no congestion via Doppler, the patient is in a fluid tolerant state. I may give additional fluid boluses, but if I start to see congestion, that's when I know that the patient is no longer responsive, and that's a hard stop, no more fluid for the patient, and then early use of vasoactive agents. So sometimes I'll give maybe a 250 cc bolus. I see the pulsatility. I say, stop, let's move to early use of vasopressors.
Great, thank you. The next question is, can you comment on continuous IV fluid in critically ill patients, which would be commonly used in small community hospitals, both in the US and worldwide?
Yeah, it's a pet peeve of mine. Nobody gets continuous fluids, period. Now there are patients, for example, TP, etc. If there's electrolyte derangements like hypernatremia, etc. So that's different, but for the most part, for me, it's a big no-no. I do not use continuous fluids, and for several reasons. Number one, I don't think it's helpful hemodynamically. Number two, people who are started on continuous fluids oftentimes realize it, and so I just don't think that it's helpful at all.
Okay, thank you. I don't think there are any more questions in the chat at the minute. Would anybody like to ask any more, or would they like to put their hand up? I think Dr. Carroll.
Grace, in the Q&A, look at the Q&A.
Oh, lovely. Thank you. We've got 2 chats going tonight. Okay.
Great. Keep them coming.
More questions. Hope you're ready for them.
Yeah, let's do it.
Do you use VTI and post-IV fluid bolus VTI, as in fluid responsiveness assessment?
Yeah. So whether you use VTI or the IVC or whatever you do, what are you looking at? You're looking at fluid responsiveness. And that's telling you whether the patient will respond their stroke volume to fluid. But as I explained previously, my goal is not to bring that patient to the point where they're no longer volume responsive. Now, I do use the VTI. I'll do it with transesophageal, or I'll do it if I get good surface views. But what I use the VTI more for is when I'm actually titrating up my inotropes. So if I do the VTI, I increase the inotropes. I see if the VTI, the area under the curve, has increased. And then I look at my perfusion markers, etc. What I'm trying to say is that whether you're looking at volume responsiveness or collapsibility of the IVC, it's not as important to me whether the patient is volume responsive. Remember, I am not trying to bring that patient to the point where they're no longer volume responsive. I am trying to figure out whether they're fluid tolerant. And this is a paradigm shift in thinking. Can I give this patient more fluid without causing harm? As opposed to, can I just give this patient fluid until I maximize their stroke volume? 2 completely different ways of thinking. And so I've really moved away from volume responsiveness, honestly. But I will use it to gauge my inotropy, yes.
Great, thank you. As straightforward as it looks, how often do you encounter patients with good quality imaging, especially those who are congested?
I think it is easier to obtain these views than it is to obtain a good view of the heart. That's what I would say. And it's even in those patients who are challenging, morbidly obese, remember, you're hunting for flow. And so oftentimes you may not even see the structures, and you'll just do color, and the color will show you the vasculature. So if you're hunting for flow, it becomes very, very easy. Obviously, you have to take into account breathing, etc. But as you become more experienced, like anything, it becomes easier and easier. So for me, I think this is very simple, bedside, and I really call it augmented physical exam for these patients.
Perfect. How can we differentiate between acute pressure overload and chronic pressure overload regarding RV?
Sorry, could you repeat that? I think.
Yeah, sorry. How can we differentiate between acute pressure overload and chronic pressure overload? Fantastic.
So this is actually the one component of the congestion cascade that I did not bring up, and that is actually RVOT Doppler. So remember when I talked about valves, pipes, and pumps? There is a pipe behind every structure. So for example, LVOT is behind the aortic valve. So flow in the LVOT tells you about the aortic valve. In this case, the RVOT Doppler tells me a lot about pulmonary vasculature. And the RVOT Doppler has a very distinct spectral waveform. And as you develop more pulmonary hypertension, you start to see the changes. And hopefully some other time we can talk about it, but that's a lecture on its own. But I can tell whether this is acute or chronic by looking at notching and the position of the notching, and whether the notching is early or late in these patients, especially if I have something to compare it to. And so I use the RVOT Doppler, which is right here, to tell me about not only whether the pulmonary pressures are high, what the impedance is like there, but it also tells me about the acute or chronicity of that pulmonary hypertension. So someone who just develops a very proximal, massive PE will have early systolic and notching. It also tells me information about the RV, because if I don't have good flow after the notching, that tells me that the RV is not functioning well. But that's actually a great question. The RVOT Doppler is something I didn't want to delve in here because it is a little bit more complex, but I believe really requires a lecture on its own. But again, that's something I do incorporate as well.
Thank you. What if we have portal hypertension? Can we use the portal pulse wave?
Fantastic. So not only portal hypertension, what do you do with cirrhotics too, right? And this is one of the science within the liver. Sometimes it will not transmit the waveforms the way it should. Why? Because you have a very stiff, contracted liver. And in those cases, you'll actually see monophasic flow in the hepatic vein. So you won't see S or D waves. In those cases, it's completely invalidated. The portal vein, for example, again, if you have portal hypertension, you may have portal hypertension higher, but you won't have a pulsatility. You're looking for pulsatility. Another reason I tell people to do this is I remember a few months ago, we had a liver transplant patient, and just for fun, after their transplant, I took a look at their liver. I could see the hepatic waveforms, but I found no portal vein waveforms at all. And that signaled to me that there's potential portal vein thrombosis, so it actually had to be emergently dealt with. So another advantage of scanning these, even in patients who have liver disease, is actually finding other pathology as well. But to answer your question, liver cirrhosis may invalidate hepatic waveforms. You're looking for pulsatility. A patient with a pulsatile portal vein, even with portal hypertension, may be consistent with more volume overload. But very, very good question.
Thank you. Got another question here. What about maintenance fluids in CTS unit, as those patients have high UOP during first hours after surgery?
So I do not do the maintenance fluids. We give fluid boluses as needed. And again, for me, it's taken a lot of convincing, but talking CT surgeons, they actually understand the importance of focus. And it's not just about a number from the SWAN. And so I incorporate my decisions with this. Now, oftentimes the surgeon may still want to do fluids, and that's okay, but that's my job to monitor to make sure it's not causing harm. And that's why I will look at the congestion cascade.
Great. And a final last question to round things up. How can the people who have attended today get any more information about your congestion cascade courses?
Okay, I'll be more than happy to forward to Dr. Kharella. I can forward to him like when we have these sessions. I hope to do them online and have people, come in from all over. So once we do that, I can also send some good material, reading material for people to kind of get more accustomed to it. So.
Great, thank you. And I think that last question is just a testament to how much people have enjoyed the session tonight. Just before I finish, has anyone else got any more questions? Anyone want to raise any hands to ask questions or put anything else into the group? Okay, I don't think there's anything else, so I think we'll conclude our session tonight. So again, I just want to say a massive thank you. You've clearly prepared very well for the session you've just given. I would just like to let everyone know that at the end of this session, there will be an evaluation form, and it will just naturally come once the session has ended. And we would really appreciate if you could send in your feedback. It helps us develop sessions that can benefit you. And if anyone is interested in speaking at any of our webinars, please get in contact with us at ICU Reach and let us know, because we're always looking for new topics and new interesting speakers. Our next webinar will be on the 12th of July, and it is on de-treatment in sepsis and septic shock, and that is by our own Dr. Kerala, and it is also at the same time, which is 9 p.m. RIA time. And furthermore, we encourage you, as always, to visit our website, www.icureach.com, to seek support and to get involved with our ICU Reach platform. So I think the last thing just to mention is we are resuming our ventilator round, and that will run every 2 weeks. The next starting on Wednesday, June 14th, so just next week. And it will be on automatic tube compensation, ATC, and that will be at 9 p.m. RIA time. Okay, I think that's everything for tonight. So if anyone else has anything to say before we finish, that would be great. And if not, thank you.
Thank you very much, Murad. That was great.
Really a big pleasure. Thank you.
Thank you, Murad. Looking forward to seeing you again, inshallah, in the near future.
My pleasure, inshallah. Thank you.
Yeah, take care. Jazakallah khair.
Thank you.